Good evening, everyone. We will be starting shortly. Please ensure that your mic is on mute and your name is visible. Also, do check that you have registered to receive your certificates after the session. Thank you for being here. Hello, everyone. Namaste and a very warm welcome to each one of you in the HepAware 2025 webinar. This is an initiative which is brought to you by GAIMS Uttar Pradesh in collaboration with, uh, I'm sorry, yeah, Namaste everyone and a very warm welcome to all of you to the HepAware 2025 webinar. This is an initiative which is brought to you by the GAIMS Uttar Pradesh in collaboration with GAIMS Mauritius and the Rotract Club of Medicrew in the observance of the World Hepatitis Day. As many of you might be aware, this year's theme is No Hepatitis, Act Now, which is a very powerful reminder that awareness and early action can save life. So in the meantime, while everyone join, we can have a fun round. So what you can do is you can scan this QR code, or you can go onto this site, and you can send the very first word that comes to your mind when you hear the word hepatitis. If any one of you have any doubt or any issue, you can send it out in the chat box. Our team is here to help you out for the same. Absolutely. The needle stick injury, one of the major causes for the spread of the hepatitis B, jaundice, inflammation. Absolutely. STD. So I can see inflammation. Many of you are sending out information. Transmission to fecal-oral route. Uh, Absolutely, one of the major causes for the spread of hepatitis A and hepatitis E, affecting the liver. Absolutely. Transmit inflammation of the liver parenchyma, diving into the history as well. Transmission via blood transfusion, definitely for hepatitis C. Greasy yellowish liver. Alcohol, definitely one of the etiological factors. Robin's textbooks of pathology. Sexually transmitted, one of the major causes in the Western countries to that. What's the major cause of the transmission of hepatitis B in the Southeast Asian countries? Someone can enter that as well. Dr. Rama, definitely Rama ma'am fans are here. It's either hepatocellular carcinoma, one of the complications, absolutely. So, uh, so now we will be starting with the webinar. We will be definitely having more of these interactive rounds after this speaker session. Uh, let's So, why we are conducting this HepAware and what is this HepAware exactly? HepAware 2025 is basically a public health initiative which has been brought to you by GAIMS, Uttar Pradesh GAIMS Mauritius, and in collaboration with the Rotract Club of the Medicrew. So, it is a student-led public health initiative which is aimed at educating the communities about hepatitis, its transmission, its types, its prevention, and the importance of testing and vaccination. This event is one of a part of a larger movement that includes school session, awareness drives, and several other sessions. So we have the speakers with us. Uh, we we will brief you about the speakers. At First, we have Dr. Nitish Mohan, sir. He is the professor and head of the pathology department at the Royal Medical College and Hospital in Bareilly, Uttar Pradesh. He is a respected academician and mentor with a deep expertise in diagnostic pathology and medical education. We are truly honored to have you, sir.
Thank you so much, Garrick.
Moving on, we have joining us all the way from Mauritius is Dr. Rama Srivastava. She is the professor and head of the Department of Pathology at SSR Medical College in Vakwas, Phoenix, Mauritius. With her rich international experience and academic leadership, Dr. Rama brings a global perspective to today's discussion. We are truly privileged to have her speak at the HepAware 2025. Welcome, ma'am.
Thank you.
Moving on, our next speaker is Dr. Akshay Kirti. He is a general physician at the Department of Medical Oncology at the Tata Memorial Hospital in Jamshedpur. He is also a postdoctoral research fellow in the infectious disease at the University of Louisville in Kentucky, United States. He is a unique blend of clinical and research expertise in hepatology and infectious disease. It is a pleasure to have you, sir, here with us.
Thank you. Thank you so much, Girick.
Thank you, sir. Moving on, so our team, without whose help it wouldn't have been possible to bring this HepAware to you. At the helm, we have Dr. Shubham Anand. He is the visionary chairman and the director of the Global Association of the Indian Medical Students, whose leadership continues to inspire a generation and generation of healthcare and change makers. Then we have Dr. Abhishek Sir. He is the president and director of the GIMS and a global representative at the WHO CSO. He also serves as the member of the World Medical Association Junior Doctor Network and the UNODC Young Doctors Network. Moving on, we have Dr. Tamanna Gar, who is the president for the GAIMS Mauritius team. Dr. Yuthika Yadav, she is the president of the GIMS Uttar Pradesh team, a committed leader who has been central to organizing this webinar and coordinating the regional outreach. And we also have Dr. Radharani Dalal. She is the president of the Rotract Medicrew, Rotract Club of the Medicrew. Her team has also worked alongside GIMS to promote community awareness and increase the participation and to promote a global outreach for this webinar. So this webinar, which is brought to you by GAIMS, it is basically a medical student network with a strength of more than 10,000 students across the globe, which is a vibrant platform for fostering the medical education, global health advocacy, and youth leadership. At GAIMS, we continue to build a global network for future healthcare leaders through impactful initiatives. One of the example is the HepAware 2025, which we are glad to have you all as a part of. GAIMS is basically a dynamic and a student-driven medical organization, and we have a growing presence in about 20 states across India, and as well as we have several of our international chapters in the countries like Nepal, Mauritius, Malaysia, Georgia, Uzbekistan, Sri Lanka, and the Egypt. Our more focused area for in GAIMS are the AMR, the antimicrobial resistance, the HIV advocacy, the hepatitis awareness that we are going to achieve through this event today, the global health education, health emergencies, and the humanitarian action. At this juncture, it's my privilege to present in front all of you initiative by GAIMS, the Project Suraksha, which is aimed at protecting our daughters and our sisters. Project Suraksha is basically a powerful initiative which is launched by the GIMS team in collaboration with the American Association of the Physicians of India, or the API, which aims to raise awareness about the HPV vaccine Through this project Suraksha, we basically try to educate all the young girls about the HPV vaccine and the cervical cancer, as it is one of the only cancer which is vaccine preventable. And but even after the presence of a vaccine, we still face one of the highest mortality rate among the females through the cervical cancer. Only these are some of the pics of the Project Suraksha that has been done by our team all across the country and in fact all across the globe. In just the first 6 months, we have tried to create a tremendous impact by reaching to about 12,000 plus girls through awareness sessions conducted in the schools. These include not only the private school but also the government school, the hospitals, and even in the religious gathering to create a greater impact and a greater awareness among the students. For under the same campaign, we have also launched several camps across the 8 Indian states and 3 countries, which we have been also facilitated by the local partners and the healthcare professionals. We have also had 5+ expert panel discussions featuring gynecologists, oncologists, and the public health professionals. At its core, I would like to say Project Suraksha is more than a campaign. It is a movement that we are carrying out to empower young girls with the knowledge and to protect the health and to create a cancer-free future. It is just a first step that we are taking in this path. Also, we would like to invite the volunteers and the educators and even the healthcare professional to join their hands with us in this life-saving mission. Uh, if any of you are interested for doing the same, uh, okay. If anyone of you would like to volunteer or collaborate with us, you can mail us at HPV. Okay, so you can mail us on HPV2025 at the gims.org. Without further ado, I would like to welcome our esteemed speaker, Dr. Akshay sir, to begin with the session. So will stop this my share screen so that you can begin.
Is my screen visible, Girik?
Yes, sir, it's visible.
Okay, great. I'll be using my iPad, that's all right?
Absolutely, sir.
Okay, great. Okay, so shall we start?
Absolutely, sir.
Okay. So, good evening, everyone. I guess majority of the people here, as I've been told, are aspiring doctors. They are medical students. And amidst us, we also have esteemed faculty members and distinguished doctors. So basically, what I want to do today is I am not going to give you a lecture on hepatitis because you're already doing that in your classrooms. You have some really good professors to teach you that. What I want to tell you today, it's going to be a very brief discussion, and what I'm going to talk is what is hepatitis and why are we talking about hepatitis? How is it so important that there is a HEPA awareness campaign which is going on? So, on that note, let's begin the evening. So, my topic would be from inflammation to oncogenesis. So, as I saw in the previous activity which was shared, a lot of people had shared inflammation, which is actually true. That is what happens. That is where the story begins. So, a warm good evening to everyone. I'm Dr. Akshay Kirti, and I'm here to talk about a clinical overview of hepatitis. So, before we begin, there's one of my favorite quotes, which I would like to tell all the aspiring doctors is a good doctor treats the disease, and a great doctor treats the patient who has the disease. And that is what our focus would be today on. We would be trying to see what is beneficial for the patient, tailor treatments according to the patient, and help you to identify these patients, not just dependent on labs, not just textbook knowledge that, oh, this AST/ALT is high. Oh, the patient has a positive HCV screening test. So the patient has hepatitis. No, there are certain clues in the history, in the physical examination that you can pick up, and then you can further dissect and further diagnose and treat the patient. So this is how the flow of the talk is going to go like. So first I'll talk about hepatitis. Then we'll discuss why it is important, what is a global burden. We'll have the statistics from WHO and CDC. We'll have a short classification in etiology. We'll talk about the viral oncogenesis, which is very important, and the clinical clues and the red flags. And then I'll have a short case in which I would like a participation where I would like to know your inputs. What do you think about the patient? So firstly, what is hepatitis? So let's get back to the basics. So I have taken the definition from WHO. So according to WHO, hepatitis is an inflammation of the liver that is caused by a variety of infectious viruses and also non-infectious agents, leading to a range of health problems, some of which can be fatal. So this definition is very important because most of the people who answered about hepatitis, a lot of things I saw was virus, hepatocellular carcinoma, someone mentioned alcohol, STD. But I remember, I think so, Girik asked that question that no one talks about what happens in Southeast Asia. So we'll further discuss what happens in Southeast Asia. So I like to classify it into three parts, basically. Okay. Either hepatitis can be viral, it can be toxin related, or it can be autoimmune. So hepatitis as a basic word, it means inflammation of the liver, hepatitis. Okay. It means inflammation of the liver. Now, why is that inflammation happening? That can be classified broadly into three categories. First is virus. All of you know that there are 5 viruses which are very important: hepatitis A, B, C, D, and E. So these are the 5 viruses which can very commonly cause hepatitis, and through various means. It can be a fecal-oral route, transmission through water, it can be sexually transmitted, needle stick injury, a lot of things. Okay. Then toxins. So toxins is a very broad category in which I have included alcohol. You have certain medications, very commonly over-the-counter prescribed medicines, acetaminophen, that can cause hepatitis. Then there are other medications as well. So this basically what happens is toxins trigger the inflammation in your liver and further lead to hepatitis. The third category, which I will not delve into a lot of detail, is the autoimmune. So like any autoimmune disease, same thing happens. In simple layman's term, your body starts attacking your own liver. Okay. And there is not a lot of evidence, but most of it is either there are environmental factors or the genetic factors. Okay. So now what is a global burden? What is the need to talk about hepatitis? Why do we have a World Hepatitis Day? So this is a map of the world. So the green part is America, the North America and the South America. The blue part is all of Europe. Okay. The red part is the African region, and you can see the small island there, that's Mauritius there. Okay, so we have a lot of audience from Mauritius. So the red part, the red island there, is your Mauritius. Then the Southeast Asia is highlighted in a shade of orange, and the pink is the Western Pacific region. If you look at the statistics, the numbers are quite high. We are talking in millions. Okay, there is nowhere any number is less than a million. In American region, we have 5 million, 5.3 million. In European, we have 10.6 million. In African regions, we have around 64.7 million for hepatitis B. In the Southeast region, which includes your India, Sri Lanka, Bangladesh, Thailand, Philippines, all these regions, they have a hepatitis B burden of 61.4 million. So this is what is going on, and that is why we have to talk about it. Because this is not rocket science. It can be easily treated, it can be easily diagnosed, and it can be prevented as well. So if you look at the global burden, there are 254 million cases. for hepatitis B, and for hepatitis C, it comes around 50 million. So moving on, the WHO estimates from 2022, there are 254 million, as we said earlier, 50 million with chronic HCV, and there are 1.3 million deaths just in the year 2022, which has almost increased from 1.1 million, which was the statistics in 2019. If you calculate the number, approximately there are 3,500 deaths which are happening daily. And these are the statistics, mind you, from 2022. So we have obviously increased, like we are increasing and improving everywhere. This is not the area which we want to improve the numbers in, but we are, sadly we are. The CDC, basically these are just the numbers for USA. This is from 2023. We have acute hepatitis B cases of 14,400 cases annually. We have chronic hepatitis B cases of 17,650. And the hepatitis B deaths are around 1,700. And for the HCV virus, we have approximately 11,000 deaths which are happening. So these numbers are something which is very concerning. It is concerning for any doctors. It should be concerning for you, not just as a citizen, but as an aspiring doctor. What can you do about it? So let's go back to the basics, as I said, classification and etiology. So this is one of the classifications which I really liked in my med school days. So this has been taken from the Dakota Gastroenterology Clinic. So I would like to give them the reference. So as we discussed earlier, you have the viral hepatitis. We know that. What are the bacterial causes? Bacterial causes can be leptospirosis. It can be syphilis. There are parasites like amoebiasis, toxoplasmosis. Okay, these are the things which also causes hepatitis. Then you have alcoholic hepatitis. Then you have the NAFLD, which is obesity related. You have chemical hepatitis. And obviously you have the autoimmune, which I don't want to delve into much detail right now. So for me as a clinician, this is what I follow. So this you won't find in any textbook. This is what I follow personally. Let's say I have a patient of hepatitis. So I see if the liver is affected or not. If just the liver is affected, then I go further to see if it is bloodborne or if it is enterically transmitted. If it is bloodborne, then you have three viruses which you need to take care of. It can be either hepatitis B, hepatitis C, hepatitis D. If you have enterically transmitted or fecal-oral transmitted, okay, or transmission through water, infected food, you have hepatitis A virus, you have hepatitis E virus, okay? Then autoimmune is, again, I don't want to delve in a lot of detail because it's a lecture on its own. Then let's say you have liver involved as a part of a general infection. Let's say the patient has a myriad of symptoms. They have a lot of symptoms, and liver is just a small part of all the symptoms that the patient is experiencing. In those cases, if the patient is having hepatitis, you can think of some common causes, which are yellow fever, cytomegalovirus, rubella, mumps, EB virus, and herpes simplex. Okay. So this is again a very textbook classification. And why this is important? Because you need to know which is a DNA virus, which is an RNA virus, because further on, when you go on to the oncogenesis of these viruses, this is very important. So the HAV, HCV, HDV, and HEV, all these viruses, they are RNA viruses. Okay. Hepatitis B, on the other hand, it's a DNA virus. Okay. And it's one of the viruses actually for which we have vaccines. And this shows you an incubation period. As I said, I want you to think like doctors now. Okay, don't think like you're medical students. You have to read textbook. You have to remember everything. Think like doctors. Okay, like you have a patient. What are the things you want to see in that patient? So one thing which is very important is you want to see the incubation period. So in hepatitis A, the incubation period is generally not very big. It's like 2 to 7 weeks. The patient will have symptoms within 2 to 7 weeks. In hepatitis B, it's generally a bit longer. It is 1 to 6 months. Hepatitis C also, it can range from 2 to 26 weeks. Hepatitis D, it is again short, 2 to 12 weeks. Hepatitis E, on the other hand, it has 6 to 8 weeks. Now you need to know what are the transmission. When we talk about hepatitis A, it's always fecal-oral. Okay, I have seen this. I remember there was one of the medical students when a patient in the ICU was admitted with hepatitis A, very severe, very elevated LFTs, and the patient was, I think, so 10 years old, and that student, he asked me that this patient, how can he have a sexually transmitted disease? He has hepatitis. How can he have a sexually transmitted disease at such a young age? So that is why you should know if there is a certain type of hepatitis. Not all hepatitis, I would like to emphasize, is sexually transmitted or is transmitted through the blood. Hepatitis A is something which is through infected food, infected water. Okay. When it comes to hepatitis B, hepatitis C, these are something which are parental in transmission. And one thing which I would like to highlight, for hepatitis B, we have a vaccine. For hepatitis A, we have a vaccine. For the other types of hepatitis, we do not have a vaccine. Okay. So generally, if the patient is immunocompromised, you would want to give them a hepatitis A vaccine to cover them from this infection. We all, I think so, everyone in this meeting have had a hepatitis B vaccine already. And once you join your hospital, you're working as a healthcare professional, you have to get booster shots for this. I don't know why this is. I think so. There was an image. Okay. So moving on to the viral oncogenesis. So what is oncogenesis? Oncogenesis is something, genesis means to give birth. Onco means in simple terms, cancer. So how these viruses give birth to cancer? Okay. So firstly, I would like to discuss about the oncogenic potential of hepatitis B virus. Okay. So you've seen, I have highlighted the direct oncogenic part. Okay. Which is very important. When I told you even initially that DNA RNA classification is very important. So when you talk about hepatitis B virus, it is a primarily DNA virus with direct oncogenic effects, which means it directly affects your DNA. It directly causes a mutation. It directly alters your DNA. And that is the reason why cancer happens. So how does this happen? So the DNA from the hepatitis B virus inserts itself into the host hepatogenetic genome, hepatocyte genome, and it disrupts the tumor suppressor genes. I'm not sure if everyone has a bit idea about the tumor suppressor genes. I think if you have read pathology, even I think so, it was the fourth or fifth chapter, Neoplasia and Robbins, you might have a bit of an idea about what the tumor suppressor genes are. So there's a protein which this virus manufactures, which is called the HBX protein. Now, what this protein does, it inhibits the P53. P53 is a very, very important tumor suppressor gene. And once the tumor suppressor genes are not working, the hepatocytes, they have a lot of cellular proliferation, and there is a reduce in apoptosis, which means the cell death is decreased, but the cell proliferation is increased, which means that the cells are dividing very rapidly, hence leading to the tumor. And also, the another mechanism is chronic inflammation. Chronic inflammation leads to repeated hepatocyte turnover, which increases mutation risk. Whenever, just remember this basic law of your body, whenever there is a very increased rate of turnover in any of your cells, more than normal, it will always have a very increased mutation risk. Increased mutation risk translates to having an oncogenetic potential. So this chronic inflammation stimulates fibrosis, cirrhosis, and leading the stage for hepatocellular carcinoma. One thing which you have to remember is that hepatitis B virus can cause hepatocellular carcinoma even without cirrhosis. Cirrhosis need not necessarily happen before it converts to hepatocellular carcinoma, unlike the hepatitis C virus. I know this can be a bit overwhelming to understand, but once I conclude my talk, I hope you have a better picture of how the patient presents to you. Now, what are the epidemiological risk when it comes to hepatitis B patients? So they have a lifetime risk of approximately 10 to 25% if you are infected with hepatitis B virus and you're not taking precautions as advised. There is a 10 to 25% chance that you might have hepatocellular carcinoma. And males in general have a higher risk, age if it is more than 40. And if you have a high level of hepatitis B virus DNA, there is a much higher chance of you having the carcinoma. Also, if you are co-infected with HCV or HIV, now this might sound ridiculous, but trust me, in your clinical practice, you might find patients with multiple tumor markers positive. Like the patient might have hepatitis B positive, they might have hepatitis C positive, and in most of the cases, even the patient is HIV positive. So these multiple viral infections makes the treatment also a bit complicated, and also the management of the patient along with their risk for the hepatocellular carcinoma. Now we talk about the hepatitis C. Now we are done with the hepatitis B. So hepatitis C virus, how does this cause cancer? Okay. This has what we call the indirect oncogenesis. So remember that HCV is an RNA virus and it does not integrate into the host DNA. But there are the indirect mechanisms which happens. Firstly, there is a chronic inflammation setting which happens. This chronic inflammation leads to a progressive liver injury, which leads to fibrosis, cirrhosis, and this cirrhosis causes what we call the regenerative nodules. And as I said earlier, if there is anywhere increased turnover of the cell higher than normal, it will have a high mutation risk. Another cause is the oxidative stress and the cytokine driven cell damage. When there is oxidative stress, due to this infective etiology, there is a huge release of cytokine. In layman's term, it might lead to your hepatitis, which leads to your hepatocellular carcinoma. Also, one thing you should remember always, again, another basic rule of your body is any long-standing infection, they can impair your immune surveillance. What I mean by this, if your immune system is not active, it might just ignore that tumor growth in your body, which is not beneficial for the body. So long-standing infection can impair immune surveillance. This is mostly the case with chronic HCV patient who have chronic hepatitis C. These patients are the prime candidates who get diagnosed with hepatocellular carcinoma, and mostly it is due to poor immune system in these patients. Now, what are the annual risk? So annual risk in HCV cirrhotics is 1 to 4%. Now, what do we mean by this? We mean that if the patient, like as I said, in hepatitis B virus, the patient might not have cirrhosis. But when it comes to hepatitis C virus, before progressing to hepatocellular carcinoma, the patient will always have cirrhosis. So in the hepatitis C positive patients who are also having cirrhosis, there is a 1 to 4% chance that they will have hepatocellular carcinoma. And also very important, there is a 20 times increase for hepatocellular carcinoma in chronic HCV patients versus the general population. Okay, this is very important. Now, what are the additional risk factors like for the patients with hepatitis infections? What are the other factors which might lead them to have hepatocellular carcinoma apart from the virus? So you have alcohol use, because basic knowledge, we all know that alcohol damages your liver. You have diabetes, you have obesity, which leads to an NAFLD overlap. Then you have HIV or HBV co-infection, which we discussed earlier, and male sex and older age. This was also discussed when we were talking about hepatitis B. So how is this clinically relevant? So I told you, I don't want you to be medical students for today. I want you to be in front of me as doctors. Let's say you have a patient who is coming to you with a positive report of hepatitis C. Positive report of hepatitis C. What are you going to do? There are treatments, yes. But how do you make sure that that patient doesn't convert to hepatocellular carcinoma? So there are guidelines for that, and the guidelines say that you should always screen for AFP, alpha fetoprotein, and perform USG abdomen every 6 months in high-risk HBV, HCV patients. When we say high risk, these patients are IV drug users or they are alcoholics, So these patients are classified as high risk. So in these category of patients, you have to screen for AFP. You have to do a USG abdomen every 6 months. Now, when will you suspect? Let's say you have a regular patient who is coming to you, everything is all right, okay? But when will you suspect that this patient might be progressing towards hepatocellular carcinoma? Number one, you'll be having worsening liver function. When we say liver function, you will check your bilirubin, AST, ALT, GGT. There are a lot of things that you're going to see on the liver function test panel. The patient will have weight loss. Weight loss is one red flag feature always in your clinical practice. Weight loss is never good. Whenever a patient comes to you with weight loss, it is never good. Most of the oncology patients that we deal with, the primary symptoms they come with is weight loss and fever. So similarly, in hepatocellular carcinoma, you will suspect if your chronic HCV, HBV patients are coming with weight loss, or if they have a new onset ascites. Ascites is basically fluid collection in your abdomen. So if they're coming with ascites, you might want to screen them and you might want to do the further tests for hepatocellular carcinoma. So what are the clinical clues and red flags? Okay, as doctors, what are the things you should see? So I will not discuss a lot of detail in what are the lab findings and what are the treatments, because I think so that's what the other speakers are going to talk to you about. So I'll just give you a brief overview. of how, as let's say you're walking to a ward, and what are the things, or you're in an OPD, what are the things you should see in a patient for thinking hepatitis? Mostly, here's a big twist, that most of the patients are asymptomatic, especially in the early HBV, HCV phases. The patients are totally asymptomatic. They will not have any symptoms at all. Here is where your laboratory screening comes into play. And how do you know you have to do those lab tests? We'll talk about that in the further succeeding slides. So we have some non-specific symptoms. You have fatigue, you have malaise, anorexia, low-grade fever, right upper quadrant discomfort. These are the some non-specific symptoms. When I say non-specific, it might be hepatitis or it might be some other disease as well, like fatigue, malaise, anorexia. It can be due to a upper respiratory tract infection. Low-grade fever, it can be due to a viral upper respiratory tract infection. Right upper quadrant discomfort, it can be due to gallstones. So it is not specific to hepatitis, but it will help you, it will give you clues thinking about hepatitis. Jaundice. Now, jaundice is one of the things you should really, really focus on. But the problem with jaundice, it often appears late. When the patient has already progressed into a chronic phase of the infection, that is when the jaundice appears. You should also see for dark urine, pale stools. These are the questions you will have to ask the patient about what is the color of your urine, what is the color of your stool. These are very, very important questions when you're taking the history of the patient. Another good thing to note is pruritus. Pruritus is, again, I would say it is a not a very specific symptom, but again, whenever you have a rise in bilirubin in your body, be it due to hepatitis or be due to a gallbladder dysfunction or anything, whenever there's a buildup of bilirubin and that bile salt accumulation happens, that is when itching happens. The patient will come to you, saying that, like my eyes becoming yellow and I don't know why I'm scratching myself all over. So those are the clues, basic clues that you really need to go ahead and order an LFT and order a viral marker test to further confirm the diagnosis of the patient. So this is how basic symptoms can help you actually go ahead and treat the patient. Now here is what I was talking to you about. From exact history taking, like my professors used to tell me in medical college that 90% of the treatment depends on how good a history is taken. Only 10% depends on the labs. I was not very sure that time. I was like, oh, that's not possible. But then once you start your clinical practice, this is something which is really important. The better history you have extracted from the patient, the better clues you have. So this are the signs from the history and exam which will give you hepatitis clues. Let's say the patient is an IV drug user, common in western parts of the world. In North America, South America, you have a lot of IV drug users. If they have tattoos, okay, this is pretty common everywhere nowadays. If they have received blood transfusions before 1992, okay, so these are the things you will think, okay, that might be hepatitis C. Okay, but obviously you have to do your labs to confirm, but this will give you a more focused approach to the patient. If the patient has unprotected sex, if there is a childbirth transmission, again, very important in Southeast Asian in countries like India, Pakistan, Bangladesh, Sri Lanka, childbirth transmission is a burden. Okay, so that is one of the most common causes of hepatitis B in Southeast Asia and South Asia, childbirth transmission. Okay, so if there's a history of this, you might think about hepatitis B. If, let's say, they have traveled to endemic regions, they are poor sanitations, you might think about hepatitis A and E. Like recently, I had a lot of patients who came and they had deranged LFTs a few months back. They had, out of the ballpark figure, like their LFTs were, AST was 1000, ALT was 1200. Okay. And they were having nausea, vomiting, jaundice. Okay. And on taking the history, most of the patients, they had traveled to the Kumbh, the annual the religious gathering which happens, the Kumbh Mela. Most of the patients were traveling back from there. So these people were very commonly affected with hepatitis A and E. This happens a lot in your rainy season. You'll see a lot of people who are eating outside due to poor sanitation. So these are the things which will give you clues that, okay, this might be hepatitis A or E. If the patient is an alcoholic, if the patient have obesity, so an alcoholic patient, you might think about that it's an alcoholic related hepatitis. And if the patient has a poor lifestyle, if they are obese, then you will think about the NAFLD related hepatitis. So this is how, without even doing any tests, you have a more focused approach towards your patient. So that is why I always tell you that the history taking is the most important part of your job as a doctor. So moving on, why do you think it matters? Like, why are we talking about this? Why I'm always emphasizing the benefit of history taking? Because if you ask the right questions, you already have the risk factors. Let's say you remember Dr. Rama's lecture, you remember what was taught in class, you remember Robin's pathology, and just, like a patient says something and it clicks, okay? And you were like, oh yeah, this was a risk factor. So let's see if it is this, okay? Also, as I mentioned, jaundice is a late sign. So you should look for subtle signs before the jaundice appears. Okay. Always remember, mild hepatitis can be missed until and unless you think about it. You have to have a very focused approach towards your patient to diagnose hepatitis before it progresses. So, yeah, what are the red flags? Okay. When you should really act fast in a suspected hepatitis. Now, when I say red flags, okay, red flags are terms which are very often thrown around in social media. So those are not the red flags we're talking about. Red flags, when I say here, it means what are the critical symptoms that warrant urgent action. Like if you see these symptoms in a patient, you immediately have to take action. You can't wait for any lab tests. You can't wait for your approvals or anything like that. Okay, you have to treat the patient immediately. First, you have altered mental status. Okay, the patient is not understanding what you're saying. The patient cannot speak properly. So that means the patient is having probably a hepatic encephalopathy. Okay, if the patient has a bleeding tendency, the gums and the gums are bleeding, the patient is having bruising. So you think of coagulopathy from liver failure, because if the liver is not functioning, no proteins are going to be manufactured, and all your clotting factors are proteins, right? So that is why bleeding tendency is also something very important. If there is a rapid drop in the blood pressure or ascites, or when we say ascites, it means the third spacing of the fluid. So most of the ascitic patients will have a fall in the BP. So this means that there is an acute liver decompensation happening. You need to treat the patient. If the INR, you do a PT INR in the patient and you see that the INR is more than 1.5, along with encephalopathy, like let's say the patient has having altered sensorium. So this means that the patient is in fulminant hepatic failure. Okay, so you have to immediately treat the patient. Now, just a brief touch on the labs. So what are the red flags on the labs? You will see if the AST/LD is more than 1000, it means that is acute viral hepatitis. If bilirubin is more than 3 to 4, then it's probably cholestasis or advanced hepatitis. If the INR is 1.5, more than 1.5, sorry, there is a liver synthetic dysfunction happening. And if the platelets are less than 100,000, the patient is going to be having a portal hypertension, which is again a chronic disease. So these are the some things in the lab. I think so the other speakers will be more qualified to discuss this. Now, what is the clinical takeaway? So early signs are really easy to miss. The red flags are very dangerous to ignore, because you ignore those red flags, like if you remember the red flags I spoke about, hepatic encephalopathy, the bleeding tendency, okay, the increased INR, all of these are fatal. The patient can die. Okay, so you should not miss it. If you see red flags, treat it immediately. Always check LFTs, INR, mental status. If the patient is in hepatitis, it's admitted under you, it's a patient in the ward, always do LFT, INR, and do a mental status examination. Okay, check the mental status of the patient. Now, what are the prevention and the WHO goals? So the primary prevention, how can we do? Like, what can you tell your patients? If you go to your schools, you give talk to school students, you can have safe injections, like no needle sharing, okay, like proper disposal of the needles. And you should have a needle stick injury protocol. I think so even basic clinics nowadays in India, they practice this safe disposal protocols, needle stick injury protocols. So that's very, very nice to see. You should have proper blood screening, which, as you remember my previous slide, which was not done very thoroughly before 1992. So proper blood screening to see if the blood transfusion is that is happening, it's not infected with any kind of hepatitis virus. Obviously, very important, the safe sex practices. Then the HBV vaccine, so HBV vaccine is once given at birth, and then there are 2 to 3 doses followed. And obviously, you have improved sanitation for HAV and HEV, especially with the flood conditions that is happening everywhere, especially in India right now. And so we need to be careful with that. And the WHO 2030 elimination goals. Okay, this is very, very important. So please pay attention to this, that the WHO has established a 2030 elimination goals in which it has decided that there should be a 90% reduction in the new infections. There will be a 65% reduction in the mortality, and 80% of the eligible people should be treated. So these are the things which we have to achieve in 2030. And we will achieve these goals through whom? Through you. You are the people who are attending this webinar, your colleagues, the young doctors, and our whole fraternity. We are the ones who will be working towards this goal. So basically, we have been given a goal, and for the next coming 5 years, we are going to work towards achieving this goal. So by 2030, we have achieved this. Now, this is a case. So you can, so Girik, like, can you drop their answers in the chat box, or is that okay? It will be an interactive session.
Yeah, absolutely, sir.
Okay, okay. So we have a 28-year-old man. Okay. He comes to your clinic, he walks into a clinic, and you start taking the history. On history taking, you notice that the patient is an IV drug user. He left it 10 years back. But when he was, in his teens, he used to inject himself heroin. He had bought a tattoo in the local parlor 5 years ago to celebrate his de-addiction. And he was very proud of it. He's flaunting his tattoo that, you know what, I'm not addicted anymore, so I'm having a tattoo here. And on physical examination, and when you ask the patient is having fatigue, there's mild jaundice, and there is right upper quadrant pain. You order some tests in the hospital. The ALT is 300, sorry. The AST is 280. And the viral markers, they are positive for hepatitis C virus. Okay, pretty straightforward, very textbook case. So I don't think so anyone is going to get a wrong answer here. This is not a quiz. This is just an interactive session. What is the most likely diagnosis? I don't think so I have access to the chats. Giri, can you read out what's the most common response? What is the most likely diagnosis?
Definitely, sir. So we are getting the response as hepatitis C.
Wonderful, brilliant. See, this is how, okay, like I purposely put that viral markers are positive for hepatitis C. But even if that is not the case, you could have figured that it's hepatitis C because, you know, the patient is having, is an IV drug user, he has a tattoo, and etc. Okay. What are the further tests needed? Anyone in the chat box? Like we have AST, we have ALT, we have done the viral markers. What else can we do in this patient? Anything. There's no wrong answer. There is no wrong answer.
HCV DNA test. We are also receiving bilirubin levels.
Okay.
Check for the anti-HCV antibodies,
Okay.
ascites,
Mhm.
INR tests, ultrasound
Okay.
of the abdomen,
Brilliant.
function test.
I think so. We should switch places. I think so. The audience are better suited to give this talk. I think so. You guys are already expert in hepatitis. All of the answers are brilliant. You would do an ultrasound. You would check for the bilirubins. I think so. Someone mentioned INR, so you would do the INR. So I think so. I feel very happy. Either I give a very good talk, or your professors are really brilliant. That you already know your stuff. So how would you counsel this patient? Okay, like let me get back to the case. How would you this is the patient. How will you counsel this patient? What will you advise the patient? Will you tell the patient to get a vaccine? Will you tell the patient to do something, change his lifestyle, anything? What will you counsel the patient? Because even patient counseling is becoming a very important part of the Indian curriculum nowadays. So do we have any answers?
Yeah, one of the responses, no vaccines are available.
Great.
Rehabilitation, supporting them and asking them to change the lifestyle, getting vaccinated and go under observation, limit
Okay.
alcohol consumption.
Okay, great. So, nice, good answers. So, obviously, you would advise them lifestyle changes, not to have alcohol. Okay, one other test which you would like to do, earlier I missed it. you would like to check for other co-infection with other viruses. You would want to check for hepatitis B, HIV. You would want to test those as well. Then you would counsel the patient to adhere to the medications, have a proper lifestyle, stay healthy, avoid any further risk factors. The table we had for the risk factors, avoid anything from them. Okay, basic. And provide them a support group. Okay, there are support groups available for hepatitis patients. Lot of I received this complaint from a lot of patients that hepatitis B patients, especially HIV patients, they feel like untouchables even in a hospital settings. They are labeled as biohazard on the files. So we can improve on that. So you can counsel them for support groups. So yeah, so I think so you all have a pretty good idea. So what are the take home points? Hepatitis has multiple causes. You have viruses, alcohol, metabolic, and the clinical clues and risk factors will guide early suspicion. Always, okay? Always think, okay? Always don't jump, because I've seen this thing with medical students. They want to jump to diagnosis. Oh, I made this diagnosis. Oh, you wanna do AST, you want to do ALT, you want to do this. Okay, no. Think first. Think about the symptoms. Prove the symptoms, talk to the patient, get a good history, then go ahead. Okay, that will give you a more focused approach rather than shooting in the blind. Okay, and especially in resource limited settings like India, where you cannot order a battery of tests because the patient will not be able to afford it. Okay, textbook says, Harrison says, okay, you do these many tests, but most of the patients come from rural areas. They're not well suited. That is where your clinical acumen, your diagnosing skills come into play. Okay, the better you are, the better doctor you are a better diagnostician. Okay, then hepatitis B and C can lead to hepatocellular carcinoma, so surveillance is very crucial. You can do AFP, you can do ultrasound. Vaccination and hygiene are key to prevention, and WHO aims to eliminate viral hepatitis as a public threat by 2030. What is your role as upcoming doctors and future doctors? You have to focus on early detection, counseling, prevention, and advocacy. Okay, I think so. GAIMS is doing a very good job in the advocacy part. They're promoting it and they're talking about it, which is very, very much needed. So these are the references which I used. I'll be happy to share those with the people who are interested. And yeah, this is me. So I was a speaker for today. And yeah, I would like to conclude by saying that this is one of my professors. He was my HOD pathology back in med school. He used to always say this, that the difference between God and a doctor is that the God doesn't think he's a doctor. So this is one of my favorite quotes. Those who know me personally, I might have told you this at some point of a time in your life. So this is very important. Okay, don't play God. You don't know everything. It's okay to have wrong answers. Okay, be a good human, be a good doctor, and treat your patients with the integrity that they deserve. Okay, and yeah, that's all for today from my side. So yeah. You can scan the QR code to get your copies. I'll be making it available after, I think so. There's a quiz after this. When it's done, you can take a screenshot of this and you can send a request. I'll make it public after the quiz is done. And you can connect with me on LinkedIn, Facebook, Instagram. I'll be happy to answer your questions and queries. That'll be all from my side. Thank you.
Thank you so much, sir. Thank you, sir, for the insightful and then enriching session. With that, it is now my honor to welcome our next distinguished guest, Dr. Rama Srivastava. Uh, Ma'am, we look forward for hearing your thoughts and gaining more from your vast experience in the field. You can share the screen now.
Yeah. Yeah, is my screen visible to you? Am I
Yes, ma'am, it
audible?
is visible. Yes, ma'am, you're audible.
Okay. So, good evening, everybody. First of all, I would like to congratulate you all for being having a strong young doctors forced to meet out so many of public issues, as I was seeing with your previous slides. And I also thank you for including me on this platform for this day of, that is Global Viral Hepatitis Day 2025, which is HepAware 2025. Is my complete screen available, or it's being cut? Let me see. Yeah. Is it
Yeah,
visible now?
yeah, we can see the
Yes.
full.
So, first of all, I would like to congratulate Dr. Akshay for putting up a very nice clinical overview of different types of hepatitis. Uh, Today, I'll be focusing more now on viral hepatitis, its modes of transmission and its prevention. And as we just said, see, today is World Hepatitis Day, so I brought some artwork here where you have some modes how you can prevent hepatitis and how you can save, basically, as you very correctly said in the previous in the previous lecture, that hepatitis is basically inflammation of the liver, which if allowed to stay unchecked can progress to liver failure and also liver cancer. So we need to prevent, we need to be aware that what are the various risk factors and how do we fight those factors to prevent this progression to liver failure and liver cancer. So for World Hepatitis Day, the theme is let's break it down. Let's break it down. That is, we break down the various stigmas, the social, economic barriers to identify hepatitis, to identify the ways it's communicated, to be aware of the risk factors, to play safe, and then if ever the infection is contracted, how do we go for testing? And for most of these infections, we should be aware that there is treatment. So we need to prevention and treatment both. So the slogan that is break it down, and slogan of this year's campaign is that hepatitis medicines are cheaper now. As I just said that there is treatment, there are antiviral medicines, but they used to be quite costly. But now the WHO aim is to make it cheaper and accessible to the wider society and treat to save lives. So as per the statistics which were earlier also given by Dr. Akshay, more than 300 million people are living with chronic hepatitis B and C. These are 2022 statistics. And out of these, it's only 45% of babies who receive the hepatitis B vaccine within 24 hours of birth. So we require a greater financial support for this purpose. And about 1.3 million people died of chronic hepatitis B and C in 2022. So that's a big number. Now let us see. So I'll take you for the next 30 minutes that what are the various hepatotropic viruses? How do we prevent those infections? And what are the risk factors? Which are the risk groups which are more susceptible? And how you can prevent it, how you can treat it. So see, we have a term hepatotropic viruses. Hepatotropic viruses, as mentioned by the previous talk, seen in the previous talk also, they have high affinity for the hepatocytes, for the liver. And you are aware of these viruses, that they are from hepatitis A to E virus, A, B, C, D, and E virus. And as this has been projected to you in the previous talk, that A virus and E viruses, these A and E, basically, they have fecal-oral route of transmission. The rest mainly have parenteral and vertical transmission. And most of these viruses are RNA viruses, except hepatitis B virus, which is a DNA virus. So I continue with these facts. And these are further statistics, which many of these statistics have already been said, but I'll quickly go through them. That you see 1.3 million people died from viral hepatitis in 2022. And till now, tuberculosis was considered to be the single leading cause of death from communicable diseases. Communicable, that is, which is transmitted from one individual to the other. Now, besides tuberculosis, viral hepatitis has also become the second leading cause of death from communicable diseases in 2023 after COVID-19. So that's a big number and that needs to be corrected. So we'll go through each virus one after the other. If you look at this hepatitis A virus, so hepatitis A virus, which is an RNA virus, and it usually causes hepatitis, which is of a self-limiting kind of condition. The main routes of transmission for this condition is the fecal-oral route. So fecal-oral route, that is usually that happens when there's poor hygiene, overcrowding, and there's consumption of contaminated food, water, milk, and in more developed countries, shellfish. You might be less aware of this shellfish. Shellfish, basically, how does it cause hepatitis A virus is that it concentrates the virus from the sea, which is contaminated with human excreta that is rich in that might be containing hepatitis A virus. And similarly, we have scallops which are used for making sushis. They are very fond of, many people are fond of sushis, and these scallops may be a rich source of hepatitis A virus because it's again a waterborne infection. Now, these are, besides that, travel to endemic areas. Travel to endemic areas, we will see what are the endemic areas where there's a high prevalence of hepatitis A virus infection. So how do you prevent hepatitis A virus infection? Basically, I was telling about the endemic areas. So endemic areas are basically developing countries where there is overcrowding, overpopulated, and there is lesser hygiene. So these are the endemic areas. Now, how do we prevent hepatitis A? So either you have active immunization. Since 1992, we have anti-hepatitis A virus vaccine. And we have two different makes where the doses, they vary depending on the age group. For the first 2 decades, it's 0.5 ml, and you have 2 doses at birth and then at 6 to 12 months. And for more than 19 years, again, 2 doses of 1 ml, which is spaced at 6 months. So this is active vaccination, while we also have passive immunization for those individuals who are usually travelers. So this is anti-HAV immunoglobulin. And for pre-exposure where you have a planned journey to endemic areas. So it depends on the duration of journey. Suppose it's just for 1 or 2 months, the dosage is 0.02 ml per kg body weight. If it is long term, that is more than 3 to 5 months, it is 0.06 ml per kg. So that provides you protection for about the entire period. So that is, and for hepatitis A prophylaxis, there are certain at-risk groups. And what are these at-risk groups? First thing is that you require routine hepatitis A vaccination of all children at increased risk. Increased risk, we mean to say they are household members, or they are living in a community centers, or they are in orphanage, or they have poor socioeconomic status, or they have a household person who has hepatitis A. So those are to be vaccinated. Or like, as I said, in certain organizations like military camps or daycare centers, primate handlers, lab workers, high travelers. But you find that injection drug users and persons with clotting disorders, right? We need to we vaccinate them prophylactically because if there's a simultaneous co-infection, it further worsens the situation. And as I said, household members of the affected individual. So these are the ones who need HAV prophylaxis. Now coming to hepatitis B virus. So if you look at the course of hepatitis B virus infection, as we just saw in the previous lecture, there's an incubation period. Usually for hepatitis B virus, we have a longer incubation of about 2 to 26 weeks, which is quite variable. And if you look at the course of disease of this virus, so in 65% cases, it causes a subclinical disease with 100% recovery. So subclinical disease, we mean to say the patient may have just vague fatigue, vague abdominal discomfort, and might have malaise, may not be going for any investigations. It might be that there may be an accidental finding that the aminotransferases are elevated, and such a subclinical disease with 100% recovery. While in 25% cases, they develop acute hepatitis. And again, in this group, 99% have recovery. That's a good part. But less than 1% develop fulminant hepatitis with acute liver failure. So that needs to be addressed. Now, in 5 to 10% cases, you find that they progress to chronic hepatitis. They progress to chronic hepatitis. They have recovery. They also have recovery, but you need to know that in 20 to 30% cases, if there are additional risk factors contributing, they can progress to cirrhosis, which may progress in 2 to 3% cases to hepatocellular carcinoma and liver failure and death. But this is again optional. It's not necessary that all cases of cirrhosis will progress to hepatocellular carcinoma, that is liver cancer. So this is a rough overview of the course of hepatitis B virus infection. Now, if you look at the incidence of HBV, you find that 1/3 of world's population is infected with HBV, and about 400 million have chronic infections. And what is important to note is that 75% of chronic carriers, they live in Asia and Western Pacific Rim. So you see, WHO has divided them into different regions. And if you look at the regions, these different regions, like you have you have African region, you have American region, Southeast Asian region, and India is included in Southeast Asian region. So you have European region, Mediterranean region, Western Pacific, where you go to a part of Central Asia, and then you move towards New Zealand and Australia. That's what is your Western Pacific region. So if you look at the percentage of total viral hepatitis, that includes B and C together, you find that the highest prevalence is in Southeast Asia. That is, the biggest bulk is contributed by India, China. And then you see next is the we have Western Pacific region. So that as I said, as I just defined the Western Pacific region. So these are the main contributors to the load of hepatitis B and C virus. And even the new infections which are coming up, the highest incidence is again in Southeast Asian region and the Western Pacific region. So this needs to be addressed. And this picture is a repetition which was well explained to you in the previous lecture. So this is the Southeast Asian region, which and the Western Pacific. So you see the highest incidence here in the Western Pacific, followed by the Southeast Asian region, which needs to be addressed. Now, this is the trend in incidence and mortality of hepatitis B virus from 2015, and we aim to reach the aims have been laid down up to 2030 that we need to eradicate, in fact, eradicate this infection. So you see here that you find that the incidence has been 1.5 million infections, and about 2022 it was 1.23 million infections, and what we aim is to bring this down and nullify it globally. So that's an important responsibility. Now, coming to the mode of transmission, to identify how do you take the preventive measures? So what are the ways it is being transmitted? So it depends on the geographical locale. Now, in high prevalence region, I said, is like Southeast Asian and the West Pacific. The most important is perinatal transmission. That is during childbirth from mother to the fetus. That accounts for 90% of the cases. Though it's usually during birth, and it's not through breast milk. This needs to be noted. And breastfeeding is not contraindicated if the mother is HBS positive. Now, in areas with intermediate prevalence, there is a horizontal transmission. Horizontal transmission, we mean to say from one person to the other. And that may be through minor breaks in the skin or mucous membranes, or following physical contact with infected individuals, as this virus is shed in most of the body secretions. So it can be transmitted through body secretions. While in low prevalence areas, you find that it is mainly due to unprotected sex and IV drug abusers, due to sharing of needles and syringes. While transfusion-related hepatitis B infection has markedly lowered down because of very stringent screening for hepatitis B surface antigen and also avoiding paid blood donors. So you find that it has reduced to 1 in 230,000 globally. So these are the various routes for transmission of hepatitis B. Just to sum up with a picture that the most common cause in the endemic areas is perinatal transmission. You need to remember that it can be through contaminated needles, syringes, tattooing, using shared razors, and even in those parlors with the hair cutting instruments, if they are infected. So you need to be particular. And unprotected sex, besides this transfusion of infection through transfusion of blood and blood products, it has almost been controlled, or it's very less because of stringent screening ways. Now, the high-risk population for which HBV screening is recommended. So first thing is that all people born in high prevalence areas where there's high endemicity. Then those people who are the household and sexual contacts of persons with hepatitis B. So the partners of people with hepatitis B, babies who are born to hepatitis B surface positive mothers, or people who have used injection drugs. It doesn't necessarily mean IV drug abusers. Even if you are on injection drugs, and if they are not disposable needles and syringes, which are a rare practice now, but still, you need to know that there can be a chance of contracting HBV. Persons with multiple sex partners or STDs, inmates of correctional facilities, as we saw, camps, jails, dormitories. So there again, people with elevated alanine or aspartate aminotransferases, it can be a subclinical infection. So they need to be screened for HBV and HCV both. Besides that, all those who are blood donors, tissue donors, or semen donors, it has to be screened for HBS. People with HIV and HCV infections, also you need to screen for HBS, because if ever there is a co-infection, it worsens or it hastens the process, resulting in more of chronic hepatitis that progresses to cirrhosis and carcinoma liver, and more of fulminant hepatitis. Now, patients of hemodialysis, pregnant females, all pregnant females are screened so that the fetus can be protected, the baby can be protected. People with accidental needle stick injury, especially healthcare workers, and of sexual assault. Now, people who require immunosuppressive or cytotoxic therapy, again, they need to be screened to prevent fulminant liver injury. So what is the vaccination schedule for pre-exposure prophylaxis of hepatitis B virus? So we have, different age groups, and we have different groups of people. Like first is for infants and children, that is from more than one, that is first year to 10 years. The doses, either we have 3 doses or we have 4 doses. If it's adult, there are 2 doses. And you have the dose now, this has been included at birth. The second is given, the second dose at 1 or 2 second month, and then at 4 to 6 months. Or we have another vaccine. So we have Recombivax and we have Energix. Similarly, 3 or 4 dosages, which are spaced in a similar manner at 0, 1 to 2, 4 to 6, or 0, 1, 2, and 12 months. So that's active prophylaxis. And besides that, there is also post-exposure prophylaxis for HBV, but that depends on the vaccination status of the exposed person. Suppose the person is unvaccinated and has an accidental exposure. So in that case, you need to give hepatitis B immunoglobulin, that is immunoglobulins against the HBV. and the dosage is 0.06 ml per kg. And after that, you can give hepatitis B vaccine series in the same manner as I mentioned in the previous slide. If the person is previously vaccinated and a non-responder, we mean to say we test for anti-HBs titers. So if the person is a non-responder, has good immunity, we do not require any further vaccination. But if it is a non-responder, again you give for hepatitis B immunoglobulins and 2 doses or 1 dose and initiate revaccination. While if there is an unknown response, suppose the patient is not aware of or we are not able to test for antibody response, we test for anti-HBsAg. If adequate, you don't require any treatment. But if it is inadequate, again, you require immunoglobulins and give vaccine booster. So that's the prophylaxis. Now, I'll very quickly go through this algorithm, which is laid down by WHO, that if the person is HBs positive, which might be due to maybe accidental, so in all those cases, who are the people who are eligible for treatment? So it depends on the severity of liver disease. So you can assess the severity of liver disease using non-invasive tests. We mean to say, are they progressing to cirrhosis? So we have certain very good non-invasive techniques like we have elastography or we have aspartate to platelet ratio. We go for ALT levels, HBV DNA levels, that is an indicator of active viral infection going on, or we seek for the medical history, presence of co-infection, especially in the endemic areas, low socioeconomic groups, or in the developed countries again, where there are increased chances of STDs, you might have co-infections. You look for the comorbidities like diabetes, or you have a steatotic liver disease, that is your fatty liver disease, or people who are immunosuppressed, like transplant recipients or autoimmune disorders, or you have extrahepatic manifestations. We have certain about 30% patients of hepatitis B and C, both where you had glomerulonephritis or vasculitis because of immune complex deposition. So in all these cases, you have to seek a detailed medical history. Now, what are the general care measures in these cases? One is counseling on the lifestyle of these people. You have to take history of alcohol consumption, as alcoholic hepatitis may coexist along with viral hepatitis. You have to prepare for starting treatment, for adherence to the treatment, and for the risk factors, like you go for the baseline investigations. And thirdly, the preventive measures. You have to screen the family members, the household members, the sexual contacts of that person, and provide them with HBV vaccination. So that is the initial assessment. Then you have to treat. So for treatment, who are the people who require treatment? So pregnant women, they are requiring, and the non-pregnant females, girls of reproductive age group. So who are the people who are given treatment? So very a broad overview. So those people who have significant fibrosis, as I just said, we have non-invasive techniques for that to assess that. Like we have elastography, we have APRI ratio of more than 1. We have clinical criteria for cirrhosis. Now, you have read your pathology, most of you, you know that they start developing coagulopathies, they start developing portal hypertension, they have varices, they have hemorrhoids. So if those features add over to your regular features like jaundice, like vague discomfort, upper quadrant discomfort, so when these add up, so these are the criteria, or you test for HBV DNA and ALT levels, they are beyond the upper limit of normal, or there is presence of any of the comorbidities, or there's a positive family history of liver cancer or cirrhosis, or there are extrahepatic manifestations, as I said, due to immune complex deposition, or they are persistently, only criteria if there is persistently abnormal ALT levels. A person is getting repeated LFTs and finding that these are elevated. In all these cases, they need to be treated for hepatitis B virus. But if you find that the person does not have all these, then you defer treatment and just need to monitor with repeated LFTs. So I said that if there is a persistently abnormal ALT levels, you need to initiate antiviral therapy, which may be a single drug therapy, or you may have combination drugs. And simultaneously, as mentioned in the previous lecture also, you need to go for surveillance with alpha fetoprotein, that is the tumor marker, and repeated ultrasounds to see the progression of disease towards liver cancer, and which has to be repeated further after every 12 months. So these are the recommendations which have been laid down by WHO. Now, in cases of, this is the algorithm for antiviral prophylaxis, if there is a mother-to-child transmission, so there has to be an HBS antigen testing. This is an antigen which is expressed by hepatitis B virus on its surface and indicates the presence of infection. So you test all pregnant women and adolescent girls. So if they are positive, you have to assess them for eligibility for antiviral prophylaxis, as we just saw. And the other test we can go for is HBV DNA or HBe antigen, which will further be emphasized by the next speaker. But I just want you to know that if there is a persistently elevated E antigen, that shows there is an active viral replication. So in those cases, you need to assess and give antiviral prophylaxis. Thirdly, the maternal intervention, that is antiviral prophylaxis, if HBV DNA is more than 200,000 international units per ml, or if there is HBe antigen positivity, you need to start maternal antiviral treatment for at least the second trimester of pregnancy and until at least after delivery. So that's the protocol laid down for protection of pregnant females and newborn against hepatitis B virus. Now, I would like to skip the slide. It's basically about the same. Now, coming to the hepatitis C virus. Now, hepatitis C virus, again, a major cause of liver disease with around 170 million individuals being affected. But you find the good thing is that there has been a decrease in the annual incidence of infection. There was a peak of 230,000 new infections, and they have come down drastically. And that is because of the reduction in transfusion associated cases, which have become very rare. And that's again because of the effective screening procedures. So if you look at the prevalence of hepatitis C, so there's a very high prevalence in the West Pacific region. We mean to say hepatitis C virus is more prevalent in the Western Pacific region as compared to the Southeast Asian region, which we quoted for hepatitis B virus. And if you look at the incidence and mortality of hepatitis C virus, so over the years, as I just mentioned, that the fortunate part is that there are less cases of transfusion-associated hepatitis, which is the main source of HCV infection. And WHO aims to bring it to complete control by 2030. So let us see what are the mechanisms of transmission, or what are the risk factors. So the main risk factors, again, are intravenous drug abuse, multiple sex partners, or having had surgery within the last 6 months where you are exposed to, where you are at risk because of the equipments or needle injury or contaminated needle syringes, needle stick injury, or if there are multiple contacts with an HCV infected individual. So mainly healthcare workers, or if there's employment in the medical or dental field. So as I said, currently the transmission of HCV by blood transfusion is close to zero in the United States. And the risk of acquiring HCV by needle stick is about 6 times higher than that for HIV. So in case if ever there's an accidental needle prick injury, you're more prone to HCV rather than HIV, which we usually used to be more scared of earlier. And for children, if we see the mode of infection, it's predominantly a vertical perinatal transmission from the mother. So these are the various modes of transmission: dialysis equipment, contaminated vaccination, and this now. See, if you look at the incidence, the highest incidence particularly is coming from needle stick injuries and also tattooing, ear piercing. So you have to be very sure that the needles used for all these procedures are completely sterile and proper care is taken. And even sharing of nail trimming instruments, shaving instruments. So these are accounting for a greater number of cases. Now, who are the high risk population for whom HCV screening is recommended is again those who use injection drugs or people with HIV infection, because again this increases the chances of progression. Hemophiliacs who are treated with clotting factor concentrates, though now it has become less common, but we need to keep in mind. Patients who are on chronic hemodialysis, unexplained elevation of aminotransferases, as hepatitis C is notorious for chronicity. It usually does not present as an acute hepatitis. It usually presents as chronic hepatitis with symptoms which appear later, and there are persistent elevated titers. And a very characteristic finding is that there are episodic elevations of aminotransferases. So in between, you find that there might be near normal levels. So these are the people who need to be who are high risk because they can be transmitting the disease. Transfusion or transplant recipients, and then children born to women with hepatitis C, healthcare personnel, sexual partners. So they all need to be tested. And we have HCV RNA testing. We have a point of care HCV RNA assay, which is now recommended to test these individuals. Now, what is the algorithm followed, which has been laid down by WHO, is that you have to conduct anti-HCV antibody testing, and we have rapid diagnostic tests, lab-based immunoassay. And if the person is positive, we proceed to viral load testing. So this confirms the current infection. So we have HCV RNA or HCV core antigen. And then if it is positive and there is established viremia, what you need to go for is and then you need to assess them. You also need to assess that is there liver fibrosis by non-invasive techniques, and are there comorbidities, is there pregnancy, are there IV drug abusers, so they have co-infection. So in all those cases, if it is without cirrhosis, you need to give antiviral treatment for 8 to 12 weeks. And if they are with compensated cirrhosis, it might need to be given for longer period, that is about 24 weeks. And they need to be monitored further at the end of treatment for sustained virological response using HCV RNA, and or we have nucleic acid tests, especially for detection of hepatocellular carcinoma. You have to screen every 6 months with ultrasound or the tumor marker, that is alpha fetoprotein. So that it requires a close monitoring. For prevention of HCV, there's no effective vaccine, as previously mentioned. And why there's no effective vaccine is because this virus, it has numerous serotypes and it changes the serotype very frequently. So the vaccine is if you even develop vaccine now, which strain is there currently, it's difficult to establish. So there's no effective vaccine, but it can be prevented by adequately screening all donated blood, ensuring safe injection practices, and safe sex practices. So that helps in prevention for hepatitis C virus. Now coming to hepatitis D virus. So remember, D is defective. Okay, D is defective, and it requires hepatitis B virus for its replication. So all those risk factors that we read for hepatitis B apply to hepatitis D infection. Now, hepatitis D virus, you need to remember that this infection occurs in two settings. Either there can be a co-infection or there can be a super infection. So if you get a co-infection means that you need to establish that first we get an HBV viral infection, and simultaneously there is HDV infection, but HDV needs the coexisting HBV infection for its replication. Okay, so it acquires the outer capsid from hepatitis B. So you need to have HBV for its multiplication. Now, how do we know that it's a co-infection? So you find that there's a higher rate of severe acute hepatitis, more severe form of acute hepatitis. If you remember the previous slides that I mentioned, that there may be subclinical infection for hepatitis B virus, but you find that right from the onset, if they are getting severe acute hepatitis, think of DV simultaneously. Or if it is rapidly progressing to fulminant hepatic failure, and especially intravenous drug abusers. So D for defective, I said, and also remember drug addicts. So drug addicts have a high incidence of co-infection and they have fulminant liver failure. And they also have higher progression to chronic infection and emergence of hepatocellular carcinoma. Just excuse me. Secondly, we can have a superinfection. Superinfection where HBV persists, already HBV persists, and now superimpose this HDV infection, which is usually after 30 to 50 days. And they usually cause sudden exacerbation of an unrecognized HBV carrier state. So as I said, that they can be subclinical carrier state, or there might be pre-existing chronic hepatitis, which rapidly flares up. And that's because of superinfection with hepatitis D virus. Now, if you look at the incidence and transmission, so we find that around 15 million individuals are affected globally. And the highest incidence is in the Amazon basin. Amazon basin, we mean to say the parts of Central America and South America. And right from your central part in South America to the Mediterranean region. So and of course, we also get in Africa, Middle East, while we find that there are lesser cases in Southeast Asia. This is might be because we are reducing the incidence of HBV with greater screening. So as compared to the drug addicts, which are greater in number, in the part of Amazon basin, we have a lesser incidence. That's the good part. And as I said, that's mainly restricted to IV drug abusers and those who have multiple blood transfusions. So we go for testing for anti-hepatitis D virus. So there are certain groups who are given priority for this. And who are these? They are particularly people born in HDV endemic regions, people with advanced liver disease who are already with chronic hepatitis, long-standing hepatitis, cirrhosis. So you go for HDV treatment testing. Those receiving HBV treatment already, and there are features suggesting HDV infection, which I said that there is sudden flaring up of the disease. Then patients of hemodialysis, patients of chronic hepatitis with C, or individuals with HIV, IV drug abusers, and sex workers, so because they are the high risk groups. Now, the approach is that we go for a lab-based HDV testing. So whenever we take a sample for HBS screening in these high-risk groups, simultaneously we test for HDV RNA and anti-HDV. And the treatment for this, besides the prevention part, which we have already mentioned, is pegylated interferon alpha. That is interferon alpha. You need to know that this is a cytokine which helps in treatment against viruses. And it's pegylated, that is glycol, which is added to it to improve its availability or biolife. Now, last of all is hepatitis E virus, which is enterically transmitted, but you need to be aware of it because wherever there are epidemics or waterborne infections, as it was just now mentioned that We have flooding going on all around in India, and also in those community-based events where there are uh, wide population getting together, where there's overcrowding, poor sanitation. So we get enterically transmitted. Enterically, that is fecal-oral route, but it is again a self-limiting disease, mainly affecting young to middle-aged individuals. Now, you need to be aware that it's also a zoonotic disease. That is, you find animal reservoirs like monkeys, cats, pigs, dogs. So those people who are animal handlers, so they are also prone to HEV infections. But what is significant is that it is responsible for 30 to 60% cases of sporadic acute hepatitis in India. That's high frequency, and it is associated with high mortality rate among pregnant females. So any case of jaundice presenting in pregnant female needs to be evaluated for hepatitis E virus, particularly if you get history of any contaminated food or water intake. So you need to screen for hepatitis E virus, and need to keep in mind that it is not associated with chronicity or persistent viremia. These virions are shed in stool, so simple stool testing for HEV RNA also helps. It can be detected in serum as well, and these symptoms they resolve in 2 to 4 weeks, and they acquire IgG antibodies which are protective. So that brings me to the last slide of my talk, that is on this World Hepatitis Day, which we are observing on 28th July today. What we are committed to, and we should be committed to, and you all being a large team, is that we have to raise the global awareness of viral hepatitis and encourage prevention, because it can be prevented. Liver failure can be prevented, cirrhosis can be prevented, liver cancer can be prevented with the various prevention measures which I have mentioned in the talk. With early diagnosis, it shouldn't be a social stigma that if you had an accidental prick or you had an accidental exposure, you feel it as a social stigma to be diagnosed. And you should be aware that the treatment is available. Secondly, to use it as a platform to mobilize action towards eliminating hepatitis. We need to eliminate, the WHO goal is to eliminate hepatitis by 2030. And that can be brought about if we have an integrated approach with educating, with bringing the awareness, using the targeting the at-risk population, and emphasizing on the preventive measures. So as I said, emphasize upon the importance of preventive measures like vaccination, especially for hepatitis B, travelers for endemic areas like for hepatitis A, safe sex practices, safe injection practices to reduce the spread of the virus. We need to highlight the need for increased access to hepatitis testing and treatment. The cost of the burden of the financial burden has to be, we need to have more finances so that there can be easy availability, easy access for testing. And we have certain point of care testing modalities that have come up. And so also assessing people with chronic hepatitis who might be unaware of the infection, and that's particularly for hepatitis C and B viruses. And last of all, a call for continued commitment and investment to achieve the elimination goals. So thank you so much for your attention. I would be happy to take if there are any questions.
Thank you so much, ma'am, for the wonderfully informative session. Your explanation has truly brought a lot of clarity to the topic that we are looking at today to gain a much deeper understanding. Up next,
Thank you.
thank you, ma'am. Up next, we are delighted to have Dr. Nitish Mohan sir. We are looking forward for an engaging session as we continue to unfold the layers of today's important discussion. Welcome, sir.
A very good evening to all of you. I hope I am audible.
Yeah, sir, you're audible.
Okay, so most of my work is already done by Dr. Akshay and Dr. Rama. They have almost covered everything. I'll just be taking, I think, few minutes of your time so that just to highlight few points from diagnostic or approach to diagnostic point of view, so that you do remember what is important for you when you go towards making a diagnosis and having a real-time diagnostic data with you. So I'll just be brief and make you go through the investigations which are available here and what you know to do at what time. So that will be a brief encounter. So may I share my PPT now?
Absolutely, sir.
Is it visible now, the full screen?
Yes, sir, it's visible.
Okay, so good evening to all of you. So hepatitis, as you know, so during my talk, I'll give you a brief introduction, which you have been listening to from past almost 2 hours. Then a one-liner on pathogenesis, one or two lines on clinicopathological syndromes, and then I'll come to my topic of approach to the diagnosis of hepatitis, which I will break into three parts, that is history, biochemical tests, and serological tests. And just an overview of these, I'll end up by showing you the flow map, which you will use to approach to the diagnosis of hepatitis. So you already know now, viral hepatitis is liver inflammation due to viral infection, and you have the names with you which are behind these, the viruses, the HIV virus, HBV virus, but it is B, C, D, and E. Out of all of these, B is the most common and the most notorious, and followed by C. Now, along with these viruses, there are systemic infections which are involving liver, like infectious mononucleosis caused by predominantly by EBV virus, then CMV, particularly in the newborns, and immunosuppressed and yellow fevers, as told by Dr. Akshay. In children and in immunosuppressed liver, these may be involved by a course of rubella, adenovirus, herpes virus, and enterovirus. So there are a range of viruses which may be directly or indirectly affecting liver. And then you have these hepatitis viruses which are directly affecting liver and causing viral death. At this point of time, you need to understand that the viruses do not directly or they are not directly cytopathic to the hepatocytes. Clinical manifestations and outcomes are always determined by immunological responses of the host. Please remember the antigens of the viruses induce or invite a cytolytic T cells to destroy infected hepatocytes, and that is where the liver injury will come into play. So that is the host immunity. The cytolytic T cells response and inflammatory cytokines which are elaborated, these are the mainstay for the pathogenesis of hepatitis. So you must know what is exactly causing liver damage in these cases. Of course, we have seen cross-reactivity with other autoantigens in these cases, but the mainstay of liver damage is by host immunity. Dr. Akshay has already told you about various clinical syndromes. I'll just outline them here: acute symptomatic infections with recovery, symptomatic hepatitis with recovery, chronic hepatitis, and then fulminant hepatitis, where there is some massive or massive hepatic necrosis. And if hepatitis is or hepatic disease is progressing to more than 6 months, then it may be put under the heading of chronic hepatitis. So, how are you going to diagnose viral hepatitis? At what time, which investigation are you going to choose? In the past two lectures, you have been stressed upon the importance of history taking. Whenever I take a class, whenever I interact with my students, I always make it a point to tell you or tell them that the most important and the only important thing that you do is interact with the patient. Right from the time the patient is walking into your OPD till the time that you have documented investigations in your hand or the results in your hand, the whole time you are observing the patient, you are interacting with the patient, and your diagnosis is made. So history is of paramount importance here in the cases of hepatitis. As you already seen routes of etiological routes or routes of transmission, so when you go upon and take a detailed history of the patient, you come to know various etiologies as you are ruling them out. So personal habits or a history of travel will indicate or may indicate infection of hepatitis A virus, a sexual activity, or you can say drug abuse, injectable history, needle prick injury, tattooing. It may indicate to you hepatitis B virus or a C virus. Then there are histories of recent blood transfusions or blood products. Then another family history will give you a history of hepatitis, liver disease, or a liver cancer can indicate to you other causes or etiologies of the liver. So you always make it a point to interact with your patients, feel your patients to be yours, where even if you are the smallest entity in that clinical unit, but feel them to be yours. Always go to patients, take up history, and try and find out lot of things that are missed on the notes or the file of the patient. So that will give you a really good indication to, yes. Now, important here is that you have a battery of investigations available for you to make up a diagnosis. But as ma'am said, Dr. Amma said that you have to offload the patient. है ना? You cannot burden the patient with a lot of investigations, and there's an additional financial burden of the patient. Then one more important thing here is that you have to reduce the turnaround time. Now, with so much of a competition between doctors, you have to have a very low turnaround time for patient or for screening of the patients. So you have to have an important aspect, that is you have to go through the patient's history, family history, his whole personal history, and lot of his personal and daily routine history and physical history. Then another important thing is physical examination. Of course, in cases of hepatitis, it is not much important or it does not give much of a clue. But then again, it can rule out major etiological coexisting diseases or any other etiological diseases which may have. Now, one more thing, that any of the etiologies or diseases which are having an effect on the liver or which are involving the liver can be ruled out very nicely from here. So physical examination is also very important. Now coming to laboratory diagnosis, how you are going to say that the said patient is suffering from said etiology or from that. So you have a panel of investigations there. You have to balance yourself with a proper clinical history, with the financial status of the patient, and then the turnaround time that you have. So you have two categories of tests which are available: the biochemical tests and the serological tests. The biochemical tests are important that so that they detect presence of liver disease, they define the pattern of the diseases, they determine the extent of liver damage, and they also help in making you follow up the response of the treatment, whatever treatment is in given. The serological tests are done for specific diagnosis of viral hepatitis to come to know which virus is behind this particular disease. As far as serological tests are concerned, the initial assessment includes the liver function tests, which has got a battery of tests. Out of them, important ones are alanine transaminase and aspartate transaminase, commonly known as SGPT or SGOT, alkaline phosphatase, direct or total serum bilirubin, serum albumin, and prothrombin time. From what Dr. Akshay said, I would now guess that you already know why prothrombin time is important. Can anyone tell me from the chat window? You can write your response. Greek, if you can help me out.
Yeah, definitely, sir.
So why prothrombin time is here as an important initial assessment?
Mhm.
Any responses?
Uh, Not yet, sir, but I'm getting some over my text to assess the liver function, to detect the coagulation disorder, to monitor
Yeah,
the anticoagulant
yeah.
therapy.
So as Dr. Akshay said that liver damage will have an effect on most of the coagulation factors because they are proteins, because they are proteins. And when there is a damage to the coagulation factors, of course the prothrombin time will increase. So initial assessment or to assess the extent of the liver damage, prothrombin time is always very necessary to be included in the initial assessment. Now, this will also indicate the pattern of this disease because you have to classify the patient as being a hepatocellular, either hepatocellular or a cholestatic etiology. And then again, you have to say if it is acute infection or a chronic infection. So your approach has to be to classify the patient as having acute or a chronic infection, and then you have to diversify the patient into a hepatocellular or a cholestatic patient. So for specific diagnosis now, you will go for specific investigations. As far as AST and ALT is concerned, it's already been said, but I'll just give you a passing reference here. AST is ubiquitously present in the body, and it is while ALT is primarily in the liver. You already know the reference range that limits set to 40 international units per liter, and any increase in these enzymes will directly tell you that there is a hepatocyte membrane damage. Necrosis may or may not be there, but rise in these levels are not as important as how much rise or the ratio of rise or the multiplication of the rise. And levels up to 300 international units are considered as non-specific, but an increase of more than 1000 international units does occur in a hepatocellular damage, for example in viral hepatitis, and this is very common. Then again, initially the time of the two, that initially AST will be higher than the ALT in acute damage. So if AST, you are going for investigations and AST and ALT both, AST is raised than ALT, then you can safely say that it is an acute damage. But if the injury is prolonged and liver damage is significant, then ALT will become higher in the later stage. So AST and ALT are done together, and this will give you classify the patient, or you can it will give you an idea of the extent of damage if it is an acute or a chronic damage to the liver. Then one another marker which is very important here is a ratio of ALT versus AST. So more than 2:1 ratio is suggestive of, or you can say more than 3:1 is highly suggestive of alcoholic liver disease. It is also known as a D-Ritis ratio. So please remember this. Again, this is a very important ratio. Alkaline phosphatase up to 3 times, again, up to 3 times of its normal value, or you can say up to 4 times of its normal value, it will indicate a cholestatic pattern of the disease. So 3 to 4 times, if it is increasing than the normal value, it will give you an indication of a cholestatic pattern of the disease. Now, serum bilirubin, direct and total indirect, you already know. So I'll just pass through that. Urine bilirubin, conjugated bilirubin can appear in the urine. So it is almost 100%, you can say, accurate, that you can give an indication of a conjugated fraction of bilirubin. And again, albumin, which is synthesized exclusively in hepatocytes, if it is less than 3 grams per dl, it will indicate a chronic liver disease. So basically, all these tests which I told you earlier, these are very good investigations which are used nowadays for initially assessing the liver damage and the time of liver damage. Then coming on to serological tests, where now, since you have basically classified the liver damage into acute and chronic and the extent of the liver damage, now you have to diagnose what has exactly caused a hepatitis. So if viral hepatitis is behind this, and which type of virus is there. Now you have to pay attention to this, as you already know there are A, B, C, D, E viruses behind, and the time of the antigen and the antibodies are variable, and based on these, you can very well diagnose the liver damage. So, presence of viral proteins or nucleic acids, you can say antigens, they are present on the viruses, and presence of or antibodies against these viral proteins may also be detected, and they may either indicate immunity or an ongoing infection. So the presence of antibodies will indicate that either host immunity has already started and as in place, or again there might be an ongoing infection in the patient. So this chart has already been shown. So hepatitis A, it is a single standard RNA virus, and infection route is pecoral, and it will mostly it is in acute. Hepatitis B, which is a partially double stranded DNA virus. It is through parental and sexually transmitted or a perinatal route, and it is seen mostly in acute and a chronic disease, both of them. Hepatitis C virus, RNA virus, and it is through parental, sexual, or a perinatal route again, and is seen mostly in acute and chronic diseases. Hepatitis D or SDV, delta agent, is a defective RNA virus. It is commonly through parental or a sexual route, and it usually requires a co-infection or a super infection with hepatitis B for its expression. Again, it can be seen in acute and chronic hepatitis as well. And then lastly, hepatitis E virus, that is HEV, is a single standard non-enveloped RNA virus. It is seen as a vertical vertical route, or a oral route, or a parenteral, and it is mostly seen in acute cases. So coming on to diagnosis of hepatitis A virus, you have already known the incubation period of 2 to 7 weeks. There are two antibodies which are uh, against this antigen, the IgM antigen, which appears in blood at the onset of the symptoms and disappears by 3 to 6 months. Please remember this, that it appears at the onset of symptoms. If the patient is symptomatic, it will appear, and it will disappear by 3 to 6 months, and it indicates an acute infection. So if you in your reports are getting IgM anti-HIV antibodies, you can safely say that it indicates an acute inflammation. Now, if you have IgG anti-AV, it follows the disappearance of IgM antibodies, peaks during the convalescence, and persists for life. So IgG antibodies will persist for life. It indicates exposure and immunity. So if the patient is giving you IgG positive, so it indicates either the patient is immunized or that the patient has been exposed. It provides immunity against reinfection by all strains of hepatitis A. So Once IgG has formed, it will stay there and it will keep providing immunity to the patient. But if IgM is positive, it indicates that the patient is in acute inflammation. HIV, hepatitis A does not usually cause chronic hepatitis or a carrier state. It only rarely moves on to fulminant hepatitis. So by this graph, you can see that hepatitis A virus will increase and decrease by the end of 6 months. So 3 to 6 months it is there, and then you can weeks, and then IgM and IgG will persist. IgM will tone down and disappear, while IgG and anti-HAV will continue. I will again stress here that the time of appearance and disappearance in hepatitis viruses is very important, which will give you a clue to acute or chronicity of the inflammation. So you can go for tests for fecal or serum hepatitis A viruses, but again, fecal and serum are not routinely done. Routinely, what we do is IgM anti-HAV antibodies for diagnosing acute illness, because IgG will give you an idea of chronicity or immunity, which will not help you in the current patient. So IgM anti-HAV antibodies will be used for diagnosis of acute cases of hepatitis A. Coming on to hepatitis B, you already know that it is a mature HBV virion, member of HepaDNA viridae family, and it is a double-stranded circular DNA. Transmission, you have already known. Incubation period is 1 to 6 months, and then chronic hepatitis. The patient lands up in chronic hepatitis in 5 to 10% of the patients, and there is risk of developing hepatocellular carcinoma. Please remember here that hepatitis B virus has got three antigens. The surface antigen, that is the outermost antigen. It envelops the glycoprotein synthesized and secreted by infective hepatocytes. Then there is a inline core where you have B core antigen, that is HBCAG, and then there is an envelope or a pre-core region which directs HBE polypeptide towards secretion in the blood. So you have that envelope, that is HBE antigen. So proteins on these layers of the virus will give you antigens, that is HBsAg, HB core antigen, that is SBCAG, and the envelope antigen, that is HBeAg. This is a genomic structure. I'll not go into details here because it's no use. It's a limited scope, maybe some other time. So hepatitis B surface antigen, it is used to diagnose an accurate acute or a chronic infection. It is first marker to appear in an acute inflammation, and its disappearance indicates recovery from infection. So it comes fast and goes fast. So persistence of more than 6 months will always indicate a chronic carrier infection, and individuals tested within 72 hours after administration of the vaccine may give you positivity to this infection. So you have to keep in mind, or you have to take history of a recent vaccination when you are going for this investigation. Again, antibody to hepatitis B surface antigen. After HBsAg, that is the antigen will disappear, the antibodies to HBsAg will appear, or they will become detectable in amount. That is, there is a constant fight, and the antibodies have been able to contain. So they will now they will reach the levels to be detectable in the serum and will remain detectable indefinitely thereafter. So they will be there. Now, window of several weeks between disappearance of HPSAG and appearance of antibodies is seen. This is also known as a serological gap. So you might not just believe that HPSAG has disappeared and there is no antibody which is detectable. So it takes random amount of time, you can say. Blood free from anti HBsAg and anti HBs, that is containing HB core antigen, is a major cause for transfusion of transmitted HBV infection. We will see that later on. And Of course, anti-HBsAg is a protective antibody. So you have now two HBC antigens, anti-HBC antigen, IgM antibody, or IgG anti-HBC. So against the HBC, IgM and IgG, these are two. Please remember here that IgM will appear in serum 1 to 2 weeks after HB surface antigen, and it will precede appearance of anti-HBsAg antigen. But the problem is that IgM anti-HBC antigen is very expensive, and it should be primarily be used if there is a high index of suspicion to indicate that the patient is in early or a convalescence or a window period. No, because you cannot unnecessarily burden the patient. Then IgG type of antigen antibody, it indicates a past infection with hepatitis B virus, and it will always be persisting for life. So if it is positive, you can say that patient has had a hepatitis B infection earlier on. Coming on to envelope antigen, it is a qualitative marker of replicative stage of the HPV. It demonstrates that the virus is replicating, so appears in a serum concurrently with or shortly after hepatitis B surface antigen, and it only transiently appears in the serum. So it is not all the time present, and it will appear only for a short period of time after HBs or surface antigen is present. So it is usually not, you can say, tested, but it may be important when the patient is having a protracted course. So antibodies to this antigen, they will appear as HBe antigens envelope. In chronic hepatitis B infections, a positive result will indicate resolving or a minimal liver disease. So antibodies will appear when immunity has been achieved or when there is a resolving hepatitis. So the individuals who are HBs positive, surface antigen positive, and have these antibodies against envelope antibodies must still be considered as infectious. So here's the chart. So you can see that the hepatitis B surface antigen will appear and will disappear around 24 weeks, and then the anti-HBs, anti-surface antibodies will appear and stay. In the meantime, as soon as they appear, IgM antibodies against the core will appear, and then IgG antibodies against the core will persist for life. So please remember this again. So diagnosis is made by hepatitis B surface antigens in the serum, which is the most commonly available investigations. When levels of hepatitis surface antigens are very low, IgM anti-core antigens can be used to establish an early diagnosis. But hepatitis B surface antigen screening test is available. It is very cheap, and the turnaround time for the test is also very less. So it is widely available, and it is also not very costly for the patient. But titers of HbsAg and HPV DNA bear correlation with the extent of DNA damage. So you can go for HPV DNA quantitative analysis, which will give you an extent to the liver damage. Screening for surface antigen will only give you positivity or negativity. But when you go, or you could take help of HPV DNA studies, you can assess how much liver is damaged based on the viral load. Now, another important aspect of assessing the viral load is that you can base your treatment upon the viral load. Then hepatitis B surface antigen and hepatitis DNA bears correlation with the extent of liver damage. I've already told you. So it is recommended that you do envelope antigen to follow up the chronic hepatitis infection, while HBV DNA tests are available for its reduction in liver and serum, and it is also an indicator for infectivity. Coming on to hepatitis C, which is also known as non-A or non-B hepatitis. But owing to poor fidelity of hepatitis C virus polymerase, the virus is inherently unstable and it gives rise to multiple genotypes and subtypes in the same infected individuals. Incubation period is 2 to 26 weeks, and more than 50% of the patients will land up in chronic hepatitis. Important thing to remember is the HCV RNA is detectable in blood from 1 to 3 weeks, and it is coincident with the elevation of aminotransferase. So if aminotransferase, as ma'am has already told, that if aminotransferase is already is raised and you are getting HCV RNA detectable, so you can very well say that hepatitis C is positive. In chronic infection, HCV RNA will persist in circulation despite presence of neutralizing antibodies. So this will suggest if it is persisting in circulation for a long time, then you can safely put the patient into the category of chronic inflammation. So you can see here in this graph that at means 6 to 12 weeks, there is a sudden rise of HCV RNA. There will be symptoms with jaundice, and the patient will be having or being in acute disease, and this will quickly go down. The HCV RNA will quickly go down, and the titers will be replaced by anti-HCV IgG and IgM antibodies. Please remember that IgG antibodies will stay or persist for a long time. Again, same goes for IgM antibodies. IgM antibodies, though low in concentration, but they will be persisting in the serum uh, for a little long time, and positive IgG and IgM will give you a clue that the patient is recovering. But on the other hand, if you have HCV RNA which is high, then you can say that the patient is in acute disease and you have to actively manage. Same way, you can say that the graph of HCV RNA in acute is a peak graph, but in a chronic disease, it will be a cup graph. So it will peak, then it will go down, and then it will peak and it will go down. So you will get a cup graph of HCV RNA in chronic cases. Now, which of the two, anti-HCV or HCV RNA? Of course, HCV RNA is the gold standard, but practically anti-HCV is enough for making a diagnosis, because you know that anti-HCV will be present in the serum, and it will give you a clue that the patient was suffering from hepatitis C. Anyway, the antigen was for a very short time. So what are the indications of routine serological testing for HCV? So based on risk of the patients who have ever injected illegal drugs or chronic hemodialysis or persistently abnormal ALT levels, you have to monitor the HCV levels. And blood donors, they should be tested routinely. Now blood donor screening, the HCV screening is a routine part of blood donor screening guidelines. And based on the recognized exposure. For example, healthcare workers, emergency medical and public safety workers, after needle sticks or sharps or mucosal exposure, they have to be tested for HCV, and then children or babies born to HCV positive mothers. So these are the indications where you will go for HCV testing. Coming on to hepatitis D, that is hepatitis delta virus. It is a unique RNA virus causing infection only when it is encapsulated by HBsAg. I have told you earlier that you have to have a co-infection of HBsAg for this virus to be coming out. So you have to have, because it is encapsulated by hepatitis virus. It only infects the liver cells which are co-infected with hepatitis B virus, and it genome replicates independently, but it does replicate independently, but the protein code, it uses the protein code of HBV for its expression. So incubation period is low, that is 2 to 12 weeks only. So in cases of co-infections, what happens? You have hepatitis D delta variant virus and the hepatitis B virus as co-infection in a healthy individual. So 3 to 4% cases will land up directly into fulminant hepatitis and will have a very bad prognosis, while 90% of these will recover with immunity, and rarely few of the patients might land up into chronic hepatitis B or D hepatitis and maybe proceed on to cirrhosis. In cases of superinfection, that the patient was a carrier of hepatitis B virus and he gets infection of hepatitis D virus. So 7 to 10% of the patients will land up into fulminant hepatitis, which have poor prognosis, and most of them, 80% of them will land up into chronic hepatitis B, D hepatitis, and which may progress on to cirrhosis. So please remember, this is a difference between two. If the patient is a B carrier and gets a super infection, it will most likely go into a chronicity. While if in a case of a chronic infection, the patient will have a good prognosis and will recover. So this is important. This is where it comes important to apply the serological tests for B virus and D virus. So IgM is the most reliable indicator of recent HDV exposure. It is identified by demonstration of anti-D seroconversion. So rise in titer of anti-HDV is the crux. So anti-HDV is often undetectable when HBsAg disappears. So you have to identify when HBsAg is also there, or it is coming as positive. So retrospective diagnosis of simultaneous infection by HBV and HDV is very difficult because it becomes undetectable very fast. So anti-HB core antigen becomes helpful because it will stay for a little longer time and it will give you an idea. Okay, there was co-infection of HBV, or the patient might have been a carrier. So that, and those in those cases, anti-B core antigen will come, antibody will come into help. So presence of IgM anti-HB core antigen is detectable in simultaneous D virus and hepatitis B virus infection, but in acute cases where HDV infection is superimposed on a hepatitis B virus, anti-HB core antigen antibody will be important and will be helpful, especially the IgG class. Coming on to the last, hepatitis E. So hepatitis E, already know, it is identified in the cytoplasm of hepatocytes during an acute infection. As you know, fecal route was the most important. So virus is shed in stool during acute illness prior to the onset of symptoms. Incubation period is 6 to 8 weeks. HEV infection accounts for over 50% of the sporadic acute hepatitis in India and exceeding the frequency of hepatitis A virus. So it is much more than. The most important about this virus is the complications, that they will land up the patient into fulminant hepatitis, and once the patient lands up in fulminant hepatitis, the mortality rate becomes higher. So what happens now is, before the onset of clinical illness, because you have incubation period of 6 to 8 weeks. So before the onset of clinical illness, HEV RNA, that is hepatitis E virus RNA, and HEV virons can be detected in stool and liver. That can before the symptoms. Once the symptoms occur, so once the rise of aminotransferase is there, then onset of clinical illness and elevation of anti-HEV antibody will be seen. So you have aminotransferase levels increasing and you have anti-HEV antibodies detectable now, but you do not get this anti-HEV RNA viral load. So there are just a passing reference to now new viral agents which have been studied or are under scanner for causing viral hepatitis. I'll just give you the names because these are not so important here, and studies are still going on. The GB virus C, the TT virus, and the SEN virus. These are recently discovered viruses, and high prevalence rates have been reported in IV drug users. And of course, SEN virus is thought to be a novel virus agent that may be linked to chronic hepatitis. But again, there is very little data in the literature still. And again, HG virus, that you can say the hepatitis G virus, it has two independent viruses, the HGV and the HBV-C. So just to give you a reference that what we are going to encounter in near future, studies are going on, and maybe we will have few more viruses for you to study in your next course. So this is a simplified diagnostic approach to patients of acute hepatitis at one place. So if HPSAG is positive, along with IgM anti-HBC core antigen, you can say the patient as having acute hepatitis B. If HBsAg is positive and none of them are positive, so you can say the patient has chronic hepatitis B. If anti-HBsAg is positive and IgM anti-HAV is positive, but IgM core antigen is negative, antibody is negative, and CV is negative, so acute hepatitis A superimposed on chronic hepatitis B, because IgM is positive here. That is why we say that the acute hepatitis is superimposed. Along in this condition, if you start getting IgM antibody, the core, so you have, when will this happen? This will only happen when you have acute hepatitis A and B, because you have IgM, core antigen. If only IgM anti-HAV is there, you do not get a positivity for HBsAg, or you do not get a positivity of B core antigen or anti-HCV. If you only getting IgM anti-HAV, so you can say again that it is hepatitis A, acute phase. If you are getting IgM anti-HAV and you are getting anti-B core IgM type, then you can say that there's a co-infection. So hepatitis A and B. HBs AG will be positive, of course, but it will not be detectable because of a low threshold, that is below the detection threshold. If you're just getting IgM antibody, these are all your quiz questions or MCQ questions. Please remember, because you will be analyzing these. So IgM antibodies are present, core antigen, IgM anticore. So only this is present. Then what will happen? Or when will it happen? It will happen when there is a acute hepatitis B. So again, why is HBsAg is not there or becoming detectable? Because it has gone under the detection threshold, and only IgM will be is there. Only anti-HCV is there and none other is there, then you can safely say that it is acute hepatitis C. You'll have to go through this again and again, and you have to, then only you will be able to realize what is happening. It becomes a little confusing, I agree, because it does become a little confusing. But once you know, or when you have, or you identify when which antigen is rising, when antigen is becoming undetectable, when which type of antibody is rising, and when which type of antibody is becoming or coming into a lower side, then you will be able to understand this much more. So I would suggest at this point of time that you go through the text again and again and again, and go through charts. A lot of these charts, if you go through, then you will be able to correlate these. And again, very important that you have to correlate with the clinical features and other baseline investigations along with these to reach a final diagnosis and to judge the extent of liver damage. Now, biopsy is always considered as a gold standard for most of the infections, and hepatitis is no exclusion. So liver biopsy, you have a lot of serological investigations and molecular tests available for hepatitis viruses. I've not gone into details, a lot of details you can say for molecular testing, because again it will take a lot of time, and diagnosis for hepatitis takes a lot of time. So I just limited my this session to only few of these markers so that you are there. So liver biopsy, now you have to judge the extent, or you have to diagnose the extent of the liver damage and the exact cause behind the liver damage, what these viruses have done. So for these cases, you will subject the patient to a liver biopsy, especially in cases of chronic hepatitis, because there are lot many causes of chronic hepatitis, and you want to safely judge, or you can detect how much liver damage has happened. So for all these cases, you have to subject the patient to liver biopsies, which is not very uncommon procedure nowadays, especially in a good settings, a tier 2 or a tier 1 setting. It is usually done for to confirm a diagnosis and to assess the severity and evolution of the disease. So what is the indication to confirm a diagnosis and to assess the severity and evolution of a disease? And of course, to exclude any concomitant diseases like alcoholic liver diseases, which are superimposed on viral hepatitis. That is important. So just an approach. First thing first, history is very important, which has been said, but again and again. Then physical examination. In cases of viral hepatitis, not so common, but again important to rule out other causes or a major other disease of other organ or organ systems which is involving the liver. Baseline lab related investigations, the LFTs, including which includes bilirubin, AST, ALT, ALP, prothrombin, albumin. Based on these investigations, you will classify the patient into hepatocellular or a cholestatic pattern. If ALT AST ratio is elevated out of proportion to ALP, it is a hepatocellular pattern. If ALP is out of proportion to ALT AST ratio, it is a cholestatic pattern. It is very important for you to make a diagnosis based on these patterns. Once you have classified the patient into hepatocellular pattern, you can go on and investigate the patients for various viral etiologies. You can take histories for drugs, ceruloplasmin, especially in cases of less than 40 years of patient, and you have to rule out autoimmune causes like ANA, SMA, and LKM by these investigations. Additional virological studies can be done for CMV, DNA, or EBV, HDV antibody, HEV, IgM antibodies. And lastly, you can subject these patients to liver biopsies. When you have a cholestatic pattern, you can either have dilated ducts or ducts. You can have to look at the dilated ducts, or the ducts are not dilated. If the ducts are dilated, you can say it is an extrahepatic cholestasis. If the ducts are not dilated, it is intrahepatic cholestasis. If it is intrahepatic cholestasis, you can subject the patients to AMA, hepatitis serology, CMV, and EBV. And again, you can confirm the extent of damage and confirm the diagnosis by the liver biopsy. So this is I will not say it's an extensive approach. I will not say it encompasses everything, but I would say I just wanted to give you a very short, brief, flow map to how you approach a patient. Important thing for you, a carry home message to you will be from my side, that you go through the transmission and the the antigens and the antibodies when they are appearing, when they are going low on under the detection thresholds. When you know these levels, then you will be able to apply this with the patient and correlate with this with the patient's history to reach up to a diagnosis, which is important. Again, now this appears to be huge, but this you have to do within a turnaround time of a 1 or 2 days only. Especially screening of the patient is done within a day or within a max of TAT of a 4 hours. So you have to apply lot of effort on in diagnosing these patients. And one important thing is that the patient will not give you time. In today's era, when there are so many options available to the patient, patient wants quick response. Patient wants quick diagnosis, and choosing a better panel for your patient which suits his financial needs, which suits his turnaround time, which suits your clinical acumen will help you in managing these patients. With these words, I would like to end my talk, and I will be available for any questions therein. It's already very late today, so I'll be available on WhatsApp. I don't usually log into LinkedIn, but there I am always available on WhatsApp. Greek will be there to share my WhatsApp number for any questions there may be. Thank you so much for giving me this opportunity, GAMIMS. And I would like to give regards to both my co-faculties, Dr. Rama and Dr. Ajay. So thank you so much.
Thank you so much, sir. Thank you for the
I'm
impactful
sorry,
and
Dr. Akshay.
thank you so much, sir, for the deeply informative and impactful session. Uh, for the part, okay, so now we can have just one of the poll sessions. The participants can log on to the QR. I see some of you have already attempted it. The others can have scan this QR or again log on to the site. This is very much based from the today's session only. I see some many of you are logging in. So I see almost about 88% have selected the option C. It is increasing. So it is very evident that everyone has learned a lot and has gained us quite an insight from today's session. So the slide which from which this whole question was based, can have a look on that. This was the slide. So as you can see, the red flags for which we need to act fast during the time of the hepatitis include the altered mental status, the bleeding tendencies, the rapid drop in the blood pressure, or the ascites, and then encephalopathy, which leads to a fulminant hepatic failure. Yes. As an extension of the Project Suraksha, those who are in Delhi, we would like to welcome them for a offline on-ground event at the Lady Harding Medical College on 31st of this month, that is 31st July. It is from 2 to 3. Um, our very own faculties from Dr. Swati Agarwal from LHMC and our LHMC representative Vanshika Agarwal. They would be the moderators for the event. If anyone is going to and is in Delhi, we most welcome them as it is one of the most important topics on the recent days in order to stop the spread of the cervical cancer and also to spread awareness about the HPV vaccination. Now, the time which most of you were waiting for, I guess. Let's begin with the quiz. You can scan this QR code. Also, I will be sharing the link in the chat box, which you can check. Just a second, I'll share the. Yogita, can we have the link over the chat box, please?
Sure, in a minute, wait.
Sure. In the meantime, you can scan this QR code. It will redirect you to the Google form on which the quiz questions are hosted. Everyone can check. The quiz link is also available in the chat box. The link will also be shared over WhatsApp. We will have, it's a very small quiz, just about 10 questions are there. As we come to the end of this enlightening session, I would like to take a moment to thank all our speakers and our volunteers and all the participants who have joined us today. Together, we can make a difference, and we are making a difference through the means of such webinars with the help of such amazing professors and such an enthusiastic participation from all around the globe. Thank you so much. And this is you can join follow us on our official channel over the Instagram, over the YouTube. Even the session was being hosted live on the YouTube if anyone wants to have a quick go through of it later on. The link has been shared over on the WhatsApp group as well. You can scan this QR code to join the WhatsApp community where we post the updates of all the latest events that are being conducted across the nation. We would also love to hear back from us and hear any feedback or any suggestions that you have. You can scan this QR code for the same. This feedback form will also be shared over the WhatsApp group. And please ensure that the registration was completed. Only the registered participants will be eligible for the merit certificate. And please ensure that you do give us a feedback. It is very essential for us to have any further improvements that you suggest. And at the end, I would like to say, stay aware, stay informed, and keep spreading the word. Thank you so much. It was truly a great session, and it was great hosting you guys here.
Thank you so much, Kirik. Thank you.
Thank you.
Thank you
Thank you,
so much.
everyone. Have a good night.